All right, so welcome everyone. Good morning. Resuming rounds after a brief hiatus for residence exams. Please welcome Dr. Michael Wan, who does MD at the University of Western Ontario, and followed by residency, of course, with us here, where he went on to complete his fellowship in pediatrics in Boston. So we welcome him back to Sick Kids, where he's taking on the torch from Camiar as our new site director for all the residents. And he is much beloved in our department for his teaching, especially his teaching in optics. So he has thrown me several years ago as the favorite optics teacher, along with Amandeep as well. He is well published in numerous papers, and we look forward to hearing what he's going to discuss with us today and his two residents, Marco and Seema. So thank you very much, Michael, for doing this.
Oh yeah, no problem. Happy to do it. Thanks for outing me as a giant nerd. Appreciate that. Yeah, so I'll just kind of jump into it. I just want to give huge credit to Seema and Marco. They had their written exam like last Friday, which apparently was a bit of a rough go. And so they put together some really excellent presentations without a ton of time to do it. And also Marco hasn't even been to Sick Kids yet, and Seema started like 3 minutes ago. So everyone be nice to them. So Marco, do you want to get us started if everything's set up to go?
Absolutely. Thank you, Dr. Wan, for the introduction. Give me one moment here to get set up. All right. Perfect. Is everybody able to see my slides here? Perfect. So good morning, everybody. My name's Marco. I'm one of the PGY2s, and thank you, Dr. Wan, so much for your support in preparing this talk. I'll go over our first mystery case here this morning. So we have a case of a 6-year-old male who presented to Sick Kids in 2015. He had a 2-month history of bifrontal headaches and bilateral vision loss for only a few days. He was previously completely well with a normal birth and developmental history. There was of note consanguinity in the family, but he did have healthy siblings at baseline and was from an Afghani background. On his exam initially, his vision was quite poor at 2400 in both eyes. His pupils were sluggish, but there was no RAPD. He had full extraocular movements of note without any pain, and he had full confrontational visual fields. His color vision was depressed in both eyes. There was an overall normal anterior segment exam, and then on the dilated fundus exam, as you see here, there was markedly evidence of optic disc edema without hemorrhage. So just starting with the first poll question here, based on this presentation, what do you think initially here would be the most likely diagnosis? Would it be something like IIH, hydrocephalus? Does he just have optic disc drusen, or is this a presentation of optic neuritis? So we'll just give a few moments for everyone to think about this one and respond.
I'm just gonna have that run for a couple more seconds, Marco. Seems like you've got a bit of a split. I'll share the results here.
All right, interesting. So some, between optic neuritis and hydrocephalus, those are kind of the leading candidates right now. So let's kind of keep on going in terms of his investigations here. And so I guess, depending on what you think, what would be the next reasonable step in this case? Should we do a B scan and a fundus autofluorescence for drusen? Would the next reasonable step to do an MRI with an MRV and a lumbar puncture for opening pressure? Should we get an MRI brain and orbits with contrast, or an urgent CT and neurosurgery consult?
Here we go.
Okay, so it seems like MRI brain is kind of the leading choice here, which is what we got. And so just to show you, I'll give you a moment here just to appreciate the MRI images, and I'll ask another poll question about this in a moment. So I'll give everyone a chance to look at the MRI to see whether they can find any abnormalities here. And so regarding that MRI, what did the findings show? Is there
Marco, maybe we can go back to the MRI while we let the poll run.
Sure. So let's come back here. So you see both the poll and the MRI here. So does it show flattening of the posterior globe and protrusion of the optic nerve, suggesting IIH? Is there enhancement and hyperintensity of the optic nerve, suggesting optic neuritis? Do we have elevation of the optic nerve head with calcium deposits suggesting drusen, or I don't know.
All right, we'll give that a couple seconds to run here.
Excellent. So most people got the correct answer here with respect to enhancement and hyperintensity. And I'll just show you the MRI here with a few arrows, just demonstrating some of that here. So the top arrow actually shows, you can actually see a little bit of the optic disc edema here, which is quite interesting via the MRI. And then you have an enhancement and hyperintensity on the T2 signal is best visualized there on the right-hand side. Of note, this patient also did have enhancing lesions in the temporoparietal region bilaterally, in addition to these findings that we see here. So going into the next poll question here, which of the following do you think is not associated with pediatric optic neuritis if this is our working diagnosis? Is it aquaporin 4 antibodies? Is it anti-MOG antibodies? Is it ADEM or ANA? All right, and so most people also had the correct answer here, ANA. So just going into some of the investigations that our patient had, obviously we've reviewed the MRI brain in orbits, and over the course of follow-up, his lesions were essentially stable. He did not have new attacks. Over 4 years of follow-ups, he did not have any new lesions after his initial presentation. There was a question as to whether there was, whether MOG antibodies were positive in this setting. Multiple tests were done. He did have one test, which was weakly positive, with the rest being negative. He was otherwise negative for NMO. The visual evoked potentials was consistent with his presentation of optic neuritis. So just for those of you who may be less familiar with VEPs, essentially either a flash or a checkerboard stimulus is introduced, and then EEG is able to capture the response to that visual stimulus. And when discussing VEP, he had delayed P100, which localizes the problem as anterior to the chiasm, consistent with a diagnosis of optic neuritis. His lumbar puncture otherwise was negative, and getting visual fields was difficult to do. Just going over the schematic here, because I think these terms MOG and aquaporin 4 and NMO are often thrown around. So just to get a sense of what is actually involved in these various conditions. Sorry here. So for MOG is actually a glycoprotein on the surface of oligodendrocytes that make the myelin. And so antibodies to this specific glycoprotein is involved in MOG disease, whereas NMO and aquaporin 4, those terms are essentially synonymous. The aquaporin 4 channel is a water collection channel predominantly on astrocytes, and antibodies to aquaporin 4 are involved in NMO spectrum disorder. So just going to the final poll question here before we end the case, which of the following are true about optic neuritis in children compared to adults? This will be a major focus of the talk here, as to comparing optic neuritis in adults and children. So do adults with optic neuritis, are they not treated with steroids, or sorry, are they often treated with steroids while children are not? Pain on EOMs, is that an associated feature in most patients with optic neuritis, irrespective of whether they're children or adults? Optic disc edema is more often found in pediatric optic neuritis as opposed to adults, and bilateral involvement is less common in pediatric optic neuritis as opposed to adults. Okay, perfect. So most people did get the correct answer in this case as well, that optic disc edema is more often found in pediatric optic neuritis as opposed to adults. And so just going over these 4 answer choices here. So, both adults and children are most often treated with steroids for this condition. Pain on EOMs is actually, very often found in adults, whereas it's not all the time found in children. Optic disc edema is more often found in pediatric optic neuritis, so that was the correct statement. And then bilateral involvement is more common in pediatric optic neuritis as opposed to adults. So just going over his treatment, he was admitted and started on high-dose IV methylprednisolone for 5 days and had a very, very good response to treatment. And he was almost close to baseline by discharge, actually. And then, but he was followed closely over a period of years and did not have any new lesions, new visual changes, and no other neurological symptoms. His final eye exam, his vision was essentially normal with normal color testing, Goldman visual fields, and you can see the resolution here of the optic disc edema on his fundus exam, with the final diagnosis being a monophasic, possibly a MOG-related demyelinating condition. So just going over some of the epidemiology and features of optic neuritis in children, it's quite a rare diagnosis. It's quoted to be about 1 in 100,000 children develop optic neuritis, and of all demyelination, optic neuritis is the most common variant. Other presentations, of course, involve other types of focal neurological deficits, sensory changes, motor changes, brainstem findings, and only a minority of optic neuritis does occur in children. I included this slide here from another Grand Rounds presentation, and this is kind of the classic way I think we conceptualize optic neuritis in adults, categorizing it into either typical or atypical forms. And I think it's important to note that what's typical in adults may not always apply. It may not always be the exact same as what's typical in children. And so here are kind of some of those findings that we alluded to earlier of how pediatrics is a little bit different. So bilateral disease is actually fairly common, and you see that on the imaging here. Reported to be in about 40% of cases having bilateral optic neuritis in children. And optic disc edema is more commonly found as well. So, in the optic neuritis treatment trial that only looked at adults, only about 1/3 of patients had optic disc edema, whereas in children, this is much higher at about 2/3 present initially with optic disc edema. Pain with EOM. So just because a patient does not have pain on EOMs does not mean that they cannot have optic neuritis. In adults, I think if pain on EOMs are not there, you really need to scrutinize and you really need to think hard about the diagnosis you're making, because the vast majority, over 90% of patients, will have pain on extraocular movements. But in children, it's anywhere from 40 to 50% have pain on EOMs based on retrospective studies. And there's differences as well in terms of the risk of developing MS. So in children, the risk is lower relative to adults, and we'll get into that in just a moment. So diagnosing this condition, as we've spoken about already, you do need to get an initial MRI with contrast. This helps for prognostication purposes. It helps to rule out other associated conditions with the optic neuritis, conditions like ADEM, as well as multiple sclerosis. And in terms of testing beyond that, a theme of this presentation is that a lot of the evidence for practice in pediatric optic neuritis actually comes from the adult trial, the optic neuritis treatment trial. And in that trial, one of the main findings is that routine testing of some of these other ancillary tests, ANA, chest X-ray, LP, syphilis testing, etc., should not normally be done for typical cases. In children, this is a little bit different, where lumbar punctures are essentially a standard of practice to rule out infectious etiologies. And on the right-hand side here, just showing an image here of deposition of IgG immunoglobulins, characteristic of oligoclonal bands, which can be suggestive of a diagnosis of MS. In terms of treatment, so different protocols vary exactly, but the main message is high-dose IV steroids. The optic neuritis treatment trial did randomize patients to high-dose IV steroids versus oral steroids alone, and found a higher rate of recurrence with oral steroids alone. And so typically the protocol in pediatrics that has been adopted for this is IV methylprednisolone 20 to 30 mg per kg per day for 3 to 5 days. And then that's followed up by oral prednisone 1 mg per kg per day over 2 to 3 weeks. You know, when considering whether to treat or observe, most patients do get treated, but it is at the end of the day a case-by-case basis. An appropriate discussion of informed consent should happen. You know, these drugs are obviously not benign, and so patients should be warned about the very systemic toxicities of steroids, including infection and adrenal suppression, psychiatric symptoms, you know, osteonecrosis, et cetera, et cetera. Overall, with adequate treatment, studies have shown that patients do quite well, actually. About 90% get back to 20/40 or better, about 80% get back to 20/20 or better. So that's an excellent result overall. So just going into some of the associated conditions with optic neuritis in children, obviously the most common association is multiple sclerosis, for which optic neuritis is the most common presentation. Just like in adults, the McDonald criteria are used to make this diagnosis. And so in simple terms, you need to have evidence of lesions that are disseminated in time and lesions that are disseminated in space. And so most often how that's made is that the patient comes in with at least 2 discrete attacks of MS and at least 2 lesions on their MRI. You know, there are different ways as well to meet the criteria. So if there's only 1 attack and 2 lesions, let's say, or multiple lesions, if some of those lesions are enhancing and others are not enhancing, that also gives a sense that some are older and some are new, meaning that there is both dissemination in time and space. Overall, younger patients are less likely to have oligoclonal bands. They're more likely to present with presentation of ADEM with a constellation of encephalopathy and flu-like symptoms as well with their optic neuritis. And they can often have these large ill-defined lesions, which I have a little bit later in the presentation. As I mentioned, treatment is still the same, high-dose IV corticosteroids. And most of MS follows a relapsing remitting course in children. And so steroid-sparing immunosuppressives are often started after the initial treatment course. So looking at the risk of MS development, I spoke about this a little earlier, that there's a lower risk of MS development in children. And so there's not great evidence around this. A meta-analysis of observational studies found about a 20% risk of MS. And so that's in contrast to some of the findings from the optic neuritis treatment trial, which found in the overall cohort for adults about a 50% risk of MS development in adults with optic neuritis. And that really did vary depending on whether there were lesions or no on the MRI. So often the numbers that are quoted are 25% if there were no MRI lesions, and then 75% if there were MRI lesions. So you get a sense that that the risk of MS is lower in children, although there are limitations to this because, you know, this meta-analysis looked at only about 6 years of follow-up, whereas the optic neuritis treatment trial followed patients for about 15 years. So the second associated condition here, we spoke about it a little earlier, neuromyelitis optica, or NMO. So this constellation of optic neuritis with transverse myelitis. And so I just listed the criteria here for this diagnosis to highlight a couple of important points. One is that if there's only aquaporin 4 antibodies present, that in and of itself cannot make the diagnosis of NMO. And conversely, it's possible to have a diagnosis of NMO even if the antibodies are negative. So you really do need to make at least 2 of the 3 criteria for this diagnosis. Obviously, optic neuritis is the most common presentation of NMO. There's literature to suggest that perhaps the prognosis in children with NMO is slightly better, though the prognosis overall with this condition is quite poor. And you know, immunomodulatory therapies, specifically rituximab and azathioprine, are often started early in these patients. And then finally, acute demyelinating encephalomyelitis. So this constellation of encephalopathy with a flu-like illness in a child with optic neuritis, especially if they're young, is also an associated condition to watch out for. You see on the imaging here how they have these large, ill-defined lesions that transcend both into the gray matter and white matter. The treatment overall is still the same, high-dose IV steroids. So just summarizing things here, overall optic neuritis in children is rare, but it can occur, and it's important to be vigilant. It's important when assessing a child who may have optic neuritis to remind yourself that their presentation can be bilateral, and that is more common in children than adults. They're more likely to have optic disc edema and less likely to have pain on extraocular movements. Steroids are still considered the standard of care in the initial phase, and there are multiple different associated conditions with optic neuritis. And finally, that MS, the risk based on the best evidence we have right now is slightly lower in children versus adults. So I just want to highlight an area here of further reading just by some of our own UofT ophthalmologists, Dr. Christakis and Dr. Reginald, who published this article on pediatric demyelinating optic neuropathies, which I found very helpful. So if you're more interested to learn, I would just consult this at the American Academy website. And I've just listed my references here. And thank you very much for your time and attention.
That's great. Thank you so much, Marco. Very well, nicely put together. We picked that case in particular because we wanted to make some points about optic neuritis in kids, kind of in particular that the presentation we sort of think of in adults with unilateral vision loss, pain with eye movements, and optic nerve, the normal looking optic nerve, doesn't really typically apply to kids, so it can look different. The other points would be that the clinical presentation, it can be a little bit difficult to differentiate, like a bilateral optic nerve edema. It can be optic neuritis, can look like high ICP, but it's really important to look for things that don't fit. So in this case, there's pretty profound vision loss, which with something like IIH, you really shouldn't have unless there's some reason, optic nerve pallor, fluid in the macula, something like that. So if you see something that doesn't quite fit, always you want to have a good explanation for it before you conclude that you think it's one thing or another. And then the last one was that the optic neuritis treatment trial was great for adults, and there's a lot of lessons for kids, but we just don't have a lot of evidence in kids. So steroids is really still considered, I think, the standard of treatment. So it's not, I don't think, okay in kids to just be like, you don't need any treatment. It really should be a more detailed discussion, and the vast majority will end up getting treatment. Cool. So I don't know if we want to do questions or can I move on to the next case?
Mike, there is a question here from Dr. Eon about whether there's any HLA predisposition.
Oh, there is for MS. I'm blanking on what it is exactly. It's like HLA-B something or other. I don't think it's particularly strong. I don't see the neuroinflammatory team doesn't typically order it. It's just been reported in the literature. So there's a 1-week association with MS, I think, but not super clinically relevant.
Hi, Mike. Could I ask a quick question?
Yeah.
That was a great presentation. Just wondering, at sick kids, for your MOG antibodies, do they test it in-house, and are they using cell-based assays? Because probably your kid in 2015 might have had an ELISA, because that was when MOG was first being kind of tested. So maybe that could be a reason why they tested negative initially. And then the second question I had is, in adults, we typically don't do LPs for optic neuritis, since the yield is really low. Just wondering, what type of infection do you see or are you looking for in your LP?
Yeah, great questions. That's a good question about MOG. I should find out. I know when he first presented, it was like an experimental test that was done in-house, and now has essentially become standard. I don't actually know the tests that they do, but that would make some sense. I mean, it would make sense in his case too, that he might be like have seroconverted to negative, and that's why it was monophasic. I'll find out, but that's a good question. For LP, the list of infections that they rule out is crazy long. For him in particular, I think they're looking for TB because he was from Afghanistan. They run it through virus testing, but honestly, I haven't ever seen one come back positive. I think the typical ones are virus, they check for Lyme, and then if there's any other kind of particular risk factors. But honestly, it's very rare. Haven't seen a single case since I've been here that actually came back positive with anything.
Mike, it's Aaron Reginald. Thanks for putting up the slide, by the way. But I also find it interesting that in puberty there's a switch from the gender predisposition to being female after puberty, and we see a lot more boys with optic neuritis before puberty as well. So that was just one piece I would add.
Yeah, no, perfect. Good point. Thank you. Okay, so I wonder for the sake of time, Seema has a cool case to go to. Maybe we'll jump to that and then take questions for everything at the end if I'm lost.
Okay, good morning, everyone. My name's Seema. I'm one of the PGY3 residents here at U of T. And I've been really lucky to recently start my Sick Kids rotation and work with Dr. Wan. And I'm really excited to tell you the second part of our pediatric neuro-ophthalmology cases this morning. It may seem like pediatric neuro-ophthalmology is rather niche, but I think that with this case, we'll find a little something for everybody. We will review an uncommon presentation of a relatively common problem. We're going to discuss how to determine optic nerve function when you're faced with a small, uncooperative patient, and review everybody's biggest dilemma when your treatment becomes problematic or runs into complications. So without further ado, we meet a patient who is slightly atypical from an ophthalmology perspective. He's a 4-year-old boy who was born at term via an uncomplicated C-section and has developed absolutely appropriately since then. His past medical history was significant for febrile seizures and pneumonia, and approximately 1 year ago, he had an episode of viral meningitis that resolved without complication. From a past ocular perspective, he had a history of resolved nasolacrimal duct obstruction. And he presented to his primary care provider with 3 months of vague, rumbling stomach aches that were happening on a daily basis, nausea, and lethargy, which his mom described as making him behave very different from his baseline. And so I'd like to start our morning with a question I'm sure you're all expecting. What is the differential diagnosis for abdominal pain in a 4-year-old? If any of you don't recognize this strange ophthalmoscope, not to worry, I'm just joking. His pediatrician and family doctor reassured the mom their diagnosis was perhaps this is a gastrointestinal virus, perhaps he's manifesting school avoidance, or perhaps this could be some somaticization of family stress that was going on at the time. In short, they reassured the mom and asked her to follow up PRN. Not quite satisfied with this answer, the mom started to think of other healthcare providers she could turn to for assistance. And she started to wonder whether there could be a connection between the stomach aches and the way he was acting and a possible difficulty with seeing at school. And so she went to see the optometrist, despite the fact that this child didn't really have any subjective visual concerns. The optometrist measured vision and dilated the pupils, and this is what they found. So as you can see here, there's bilateral elevation of the optic discs, which is hyperemic and kind of fluffy in appearance. He took one look at this child and sent him straight to the emergency department at Hospital for Sick Children to rule out possible papilledema. This is where we met our patient. On examination, he was a healthy appearing child of normal height and weight, although he did seem quite tired. On review of systems, in addition to the stomach aches, he did endorse some occasional headaches. These were very vague again and difficult to quite characterize. His anterior segment examination, visual acuity, extraocular motility, and cranial nerve examination was all benign, and there was no RAPD. In addition to a dilated fundus exam, we performed a B scan, which you can see here. And as you can see at the optic nerve, there are hyperechoic plaque-like lesions at the optic nerve, as well as you can see here on this slice, some elevation of the optic nerve. So putting it all together with the clinical examination, the B scan, and the history, I'm just going to start the poll, or perhaps ask Amandeep to start. Thank you, Amandeep. Faced with this patient, what do you think is the most likely diagnosis here? Would you describe this as papilledema, buried optic disc drusen, pseudopapilledema without drusen, or potentially anomalous optic discs? So I'll let that run for a moment. I'm curious to see what everybody's opinion is.
This is great, Seema, because you've got a nice split here. I'm going to just share the results in a second.
Okay, so we have quite a split between buried optic disc drusen, pseudopapilledema, and papilledema, which is fantastic. That's pretty much what we wrote on our consult notes and sent him back to the emergency department, saying there is bilateral optic nerve elevation, likely optic nerve drusen, but cannot rule out papilledema. The emergency room physician commented that there were no other clinical signs of increased ICP to add to the clinical picture. So faced with this child, I'm going to turn it back to the audience again and ask, what would you do next if you were faced with this 4-year-old boy with elevated optic nerves, a stomachache, and headache? Would you observe him for now? Would you obtain an MRI brain and orbits, send him for an urgent CT head to rule out a space-occupying lesion, or get some other smart brains involved and ask for a neurology consultation?
Thank you, Seema. So I'll let that run for a second, although it's starting to look like MRI brain and orbits is the big winner here, but it can be difficult in a 4-year-old. So I'm curious to see what you guys did.
So, I don't think there's really a wrong answer here. When we were discussing this case, you could probably do a combination or one or other of these options. It does seem like ordering an MRI is often the answer in ophthalmology. However, it is important, just as Amandeep mentioned, that obtaining an MRI is not necessarily easy in children. Often you do need sedation in order to complete these long scans and get a good exam. And another thing to keep in mind is that a CT of the head can be difficult to convince the radiologist to perform in a 4-year-old child, because although there is relatively low risk of long-term oncologic outcome with that level of radiation, it is something to consider. So this patient was discharged with an outpatient MRI and MRV of the brain within 1 month. And as you can see here on the left-hand side, the MRI of the brain showed engorgement of the optic nerve sheaths bilaterally, but it was otherwise relatively normal. There was no space-occupying lesion found. And when we looked at the MRV, it was largely patent and had no abnormalities. You can see here on this sagittal scan that there was a partially empty cella, which can be considered a soft sign or an indirect sign of raised ICP. And this certainly fit with the lumbar puncture that was also done under sedation, which had an elevated opening pressure of nearly 50 centimeters of water. So putting this all together, we have a 4-year-old previously well boy who's presenting with chronic stomach aches, headaches, and lethargy. He has bilateral optic disc edema with preserved vision on examination. His MRI and MRV have been normal, as has been his blood work, which also included an extensive infectious and autoimmune panel. And so far, the biggest abnormality on his investigation has been elevated opening pressure on lumbar puncture. Putting this all together with the help of our colleagues in pediatric neurology, we came to the diagnosis of pediatric idiopathic intracranial hypertension, which is what I want to speak to you guys about today. Before we jump into it, I'd like to get a sense of what everybody knows about IH. So which of these statements do you think is false? Prepubertal IH does not have a gender predilection, or young children with IH are typically overweight or obese. 3, steroids can be used for treatment of pediatric IH. Or 4, high intracranial pressure in children is considered when it is above 28 centimeters of water. Okay, so many people seem to be quite on the mark with this one. It's true, young children with IH are not necessarily overweight or obese, and we're going to talk about this a little bit more in a moment. So pediatric idiopathic intracranial hypertension, or pediatric IIH, is a diagnosis that is made when there is raised intracranial pressure in the absence of a space-occupying lesion and when there is found to be normal cerebrospinal fluid composition. It is certainly a distinct entity compared to its adult counterpart, and it is much less common. Less than 1 in 100,000 children will be diagnosed with this disorder, whereas amongst obese young women, which is who we typically think of with this diagnosis, the incidence is more than 20 times more common. And it's an important entity to think about and keep on your differential because there is significant morbidity and vision loss that can be associated with a delayed diagnosis. I've put these diagnostic criteria up on this slide, not so much to go into the nitty-gritty, but to talk about the fact that the diagnosis of IIH is not black and white, and it is not an exact science. The modified Dandy criteria are often talked about in adults, and it relies quite heavily on signs and symptoms of increased ICP, which can actually be quite difficult to elicit in children. They may be vague about headache or nausea. And as well, the CSF opening pressure is set at over 25 centimeters of water in this criteria. In contrast, the more recent PTCS criteria on the right-hand side kind of has a bit more of a nod towards the difficulty in diagnosing this condition. There are categories for definite, probable versus suggested pediatric IIH, and it does include guidelines for pediatric LP opening pressure, because a lot of children have their LP under sedation, which can artificially lower the pressure. As well, there's less emphasis on symptomatology and therefore a bit more reliance on radiographic signs. IIH in children can often be thought of as two conceptually different entities. The first is primary IIH, in which children who, we can think of them as two different children. So in post-pubertal children, they tend to fit the classic phenotype, meaning children who are female, perhaps overweight or obese, and again, of reproductive age, so after puberty. In prepubertal children, these tend to be kids who may actually have a thin body habitus or a normal BMI, and they may be male or female. So in essence, in this primary group, children may have a risk factor associated with IH, such as obesity or female gender, but they also may not. And there's no other clear inciting factor associated with the development of this disease. In secondary IH, there's actually thought to be an association with an entity that is associated with increased intracranial pressure. So some of the well-described entities that are associated with IH include the use of vitamin A derivatives, tetracyclines, use or withdrawal of steroids, as well as various endocrinopathies such as thyroid disorder or use of growth hormone. In children, it's also been well described that IH can be associated with autoimmune disease, anemia, renal failure, as well as Down syndrome and Turner syndrome. The differences between adult IH and pediatric IH are quite significant. So whereas adult IH is typically seen in women between the ages of 20 to 50, pediatric IH can be seen in children as young as 2 and 3, and then it goes right into adulthood. And the line in the sand in differentiating the different phenotypes tends to be around the onset of puberty. It's interesting, however, that the prevalence does increase with age, so it's more common in the post-pubertal group. As we've alluded to before, post-pubertal and adult IIH is seen much more commonly in females, whereas in children before the age of puberty, there's a 1-to-1 ratio of males and females. Similarly, after puberty, there's a strong association with obesity in children with IH, whereas children who are pre-puberty are much less likely to are more likely to have a normal BMI. And finally, the way that IH can present in children and adults can be quite different. So adults may complain of what we consider to be the classic ICP headache associated with raised ICP, meaning a headache that's worse in the morning, that improves with lying down, and has a tight, throbbing sensation. Whereas children may have atypical headaches and more commonly present with neck stiffness that may make you worry about meningitis at first. Adults also may be able to describe things such as transient visual obscurations or pulsatile tinnitus, whereas the subjective symptoms you may elicit in children might be limited by their ability to describe them. Finally, although abducens nerve palsy is the most common cranial neuropathy seen in IH in both adults and children, children can much more commonly present with palsies of cranial nerves 3 and 7. Diagnosing IH from an ophthalmic perspective could also be really challenging in small children. First of all, children typically have a very full appearing optic disc with a smaller cup, which, especially if you have only a fleeting glance at the optic nerve, can be really difficult to differentiate from optic nerve elevation. This is where fundus photography can be your friend because it's a quick flash of light and allows for comparison over time. So this is definitely a diagnosis in which you want to enlist your neighborhood ophthalmic imaging specialists. As well, in children, there can be buried optic disc drusen, which are less likely to be calcified and much deeper than in adults. And we know that in children, our standard technologies for detecting optic disc drusen, such as B-scan and fundus autofluorescence, have a reduced sensitivity, which is only about 50%. So it can be very difficult to differentiate papilledema from drusen. OCT has also become an increasingly important ancillary test in understanding elevated optic nerve fibers. And this can be challenging in children because it requires comprehension, cooperation, and good visual acuity. So it can be really challenging to follow the thickness of the peripapillary RNFL in kids. And finally, visual field testing is one of our most important ways of measuring optic nerve function globally. And it can be very, very challenging in small children. Goldman visual fields can be used in children from the age of 5 and up, whereas Humphrey visual fields require a very cooperative child and are typically limited to children who are at least 8 years old or above. Finally, many of the procedures that we will talk about in a moment that we require to make a formal diagnosis of IH may require sedation. So that can include intubation and a general anesthetic, which you really have to be sure that you've done your thorough ophthalmic examination and it's worth it to go down that road. So what are the important things to order when you do think there's a possibility of IH? First, you want to make sure that you have a high quality MRI of the brain and orbits with contrast to rule out any space occupying lesions and better characterize if there are indirect markers of increased ICP. A lumbar puncture that's done under sedation for best outcome is also critical. As well, there is a bit more emphasis on some blood work in children. In addition to CBC and a basic metabolic panel, we often also test ANA and other markers of autoimmune disease, as well as thyroid function, which is less of a consideration in adults because there tends to be less of an association with secondary IH. And finally, given the complexity of these children, this is definitely a disease that you want to collaborate early with your pediatric neurology colleagues, whereas in adults, you may feel more comfortable managing IH alone as a neuro-ophthalmologist. When it comes to treatment, we can think of it in 3 broad categories. First, in terms of lifestyle, we often recommend weight loss for adults. And while this may be appropriate in post-pubertal children where weight loss may be implicated in the disease, this may not apply to a prepubertal population with IH because weight is not as implicated as a factor in the development of the disease. Even in children who are post-puberty and may require some weight loss, this can be quite difficult because we're still trying to maintain normal growth and development in these children. So weight loss should really only be undertaken in conjunction with a pediatrician. First-line medications for treatment of IH are similar to adults in that we typically start with acetazolamide to reduce production of CSF. Second-line treatments can include topiramate and furosemide. And in very fulminant or refractory cases, that can be consideration of use of corticosteroids. Finally, in the toughest cases where medical management is not working, we often consider surgery. And these procedures can include CSF shunting procedures like a lumboperitoneal shunt, optic nerve sheath fenestration, or something that's emerging in the pediatric world is neurovascular stenting. A quick word about steroids in IH. Prednisone has an interesting relationship with the production and absorption of CSF fluid. It's thought to lower both of these, and it's also thought to interact in a very complex way with the hypothalamic neuroendocrine axis that's been implicated in the pathogenesis of IH. So all of this to say that it seems to interact with the production, absorption, and flow of CSF, but it's not very well understood how it contributes. It's also thought to contribute in IH to treatment of a potential inflammatory component of the disease. So although there are case reports going back many decades of the use of steroids to treat IH and many reports of people improving, it can also be a bit of a double-edged sword because as we know, the use of steroids can worsen weight gain, which may progress the disease. As well, tapering steroids has also been associated with increased papilledema. So it can lead to a bit of a vicious cycle in treatment of this difficult disease. So going back to our 4-year-old boy who presents with the optic nerve seen here on the left, we actually brought him back many times in a row, trying to get an OCT to get a little bit more information. And when we were finally able to get the OCT, you can see here that there were very elevated optic nerves. So like many things in medicine, and particularly in pediatrics, often multiple attempts in using different techniques is important to get the imaging or investigation that you need. So in conjunction with pediatric neurology, he was started on urgent treatment. Unfortunately, this was a very difficult road for our patient. On Diamox, he developed extreme lethargy, he had anxiety and was unable to sleep. In an attempt to get him off of the acetazolamide, we trialed topiramate, which made absolutely no difference in his symptoms and had insufficient ICP control. So finally, a last-ditch effort was made to attempt prednisone. And as we all know, prednisone is associated with many systemic toxicities, and this poor child developed many of the side effects. He developed severe steroid-induced osteoporosis with multiple compression fractures before the age of 7. He gained a substantial amount of weight and developed adrenal insufficiency that was associated with severe adrenal crises with several admissions to the ICU. As you can imagine, the team was very eager to get him off of these steroids, but every attempt to wean him down led to worsening of his symptoms. A last-ditch unorthodox attempt was made to used to try azathioprine as a steroid-sparing treatment, which is certainly not part of our usual toolbox in the treatment of IH, but unfortunately this failed. And so, faced with failing medical management, what next? The parents were given a long discussion about the options for different surgical management. So whether this be CSF shunting, like we talked about, optic nerve sheath fenestration, which was felt to be technically challenging in this child, they actually elected to undergo dural venous sinus stenting. And this was the first child in Canada and one of the first 10 in North America to undergo this procedure. Dural venous stenting is performed typically by interventional radiology. They find access via the femoral artery and thread a catheter into the sagittal sinus and the transverse sinus of the brain to try to increase the venous outflow around the brain. Some of the challenges with this can be difficulty in finding child-sized catheters. And of course, there is extremely limited safety and efficacy data amongst the pediatric population, although this is becoming more frequently used amongst adults. Unfortunately, despite all of this treatment, this child went on to have a very difficult course, and he has still not been able to be fully weaned off of steroids or acetazolamide. 3 years on, he has developed optic nerve pallor that you can see here bilaterally, and there has been progressive loss of the ganglion cell layer seen on OCT at the bottom of the slide. As well, Goldman visual fields, which we've been able to incorporate as he's grown older, show constriction of both visual fields with loss of the superior visual field and nasal visual field in both eyes. So I feel like although we've discussed a very challenging case, I think there are some take-home points from this case that are applicable to any ophthalmologist. Rule out papilledema is a common consult for anybody who carries a pager, whether you work at a pediatric or adult hospital, and it's important to keep pediatric IH on your differential, as it is something that can certainly present. Remember that children may present with uncommon symptoms. For example, there are more males you may see with this condition. They're less likely to be obese, and their headaches may be very atypical. But if you are thinking about this diagnosis, do not hesitate to get the investigations in order, because permanent vision loss can happen in 10 to 20% of children, especially if there is a delayed diagnosis. And to that end, timely neuroimaging is very important, but requires careful consideration and thought to the modality and the sedation that may be required. So with that, I just wanted to say thank you for your attention, open the floor for some discussion, and wish everyone a very happy holidays.
Great, thank you so much, Seema. That was very excellently put together, pretty complex case, so nicely put, nicely presented, nicely researched. I gave you, like, I think the most complicated case of IH that I've ever seen in my life. So, because I'm, I don't know, a horrible person. So thanks for doing that. Yeah, and just one of the main point of this too was kind of what Seema just said, is that IH in kids is not common, but before puberty, it looks a lot different than what we normally see. Often atypical symptoms, often skinny, often male. And the testing, really, bruising can be difficult and getting imaging can be difficult. Just as a general kind of principle, this is a really bad case. So Aaron, Reginald, and I are kind of reviewing the IH cases at sick kids, and there's been 100 or so from the last 10 years. And this is the only kid who ever underwent surgery. So most of them actually do pretty well. So with that, I think we have a couple minutes left if anyone has any questions, or if they want to grill Marco and Seema.
I just wanted to ask a question. You were saying there was drusen and papilledema initially?
You know, it's a good question. I don't really know. The first B scan I saw, I thought that it was enough to look like drusen, and the symptoms weren't typical for me, but we've B scanned him since, and it's not super convincing. No fundus autofluorescence. The OCT finding's not convincing. So I think probably more it's just papilledema, and we caught a bit of perpendicular kind of reflex or something like that. So I think it's no papilledema, and if there was drusen, very mild.
And looking
have
at
you-
the images, I think there were multiple attempts to do B scans, and he was quite challenging at that age, so it was very difficult to make that diagnosis.
I think what I've transitioned to, and probably the new gold standard for drusen, is enhanced depth imaging OCT over the nerve. So do you guys have that at Sick Kids? And this is a case where it might have been helpful to have it, because there is some trouble when you defer to neurology and rely on the opening pressure, because that can be unreliable and you can result in overdiagnosing a lot of kids based on the opening pressure. So it's a tough job in kids because obviously you can't get these ancillary testings as easily. But we've transitioned to OCT, enhanced depth imaging, since that gives us, I think, some better information.
Oh, that's a super good point. That's really, really interested in that too. We just actually, Sick Kids, we just published a paper, it's accepted in CJO, looking at OCT and drusen. I think it's going to be the gold standard. It just seems like it almost can't not be, although I found that it still seems to be a bit evolving to me. Like some of the early papers had the kind of hyper-reflective mass, and then that turns out this has been recalled foams. You know, this very terrible acronym, like these peripapillary hyperintense ovoid mass-like structures, which may be drusen, but also may be papilledema. So I'd be interested to know what you think, Jonathan, about that in terms of, do you find that the enhanced depth OCT is really sensitive and specific, or are you still kind of working through what you would consider drusen versus papilledema?
I think we're getting it routinely now at Kensington because we have the enhanced depth imaging modality. It does require some expertise to interpret it, but if you get a good scan through the nerve, I think that's the most reliable way I diagnose drusen now.
Yeah, I think this is going to be the next thing, especially because B scans are not universally available. They're only about 50-ish% sensitive in kids. Same with fundus autofluorescence. So yeah, once we get, I think, a good protocol, at least for that I've seen in terms of how to use OCT and get some better numbers about sensitivity and specificity, I think it's going to be the gold standard not too long from now.
So, Seema, I think you have a heckler. Dr. Tehrani's got a question. Would you have considered doing optic nerve sheath fenestration in Seema's case, and if so, when?
Sorry, I just want to ask the question myself. So I just
Yes.
wanted, I mean, I see the visual field, and although there's a little bit of constriction, it's not a terrible visual field, but this child has got optic disc pallor. So at what point would you have then offered to the parents to maybe have optic nerve fenestration?
Yes, good question. So this is I find this a really fascinating area. Like when I was in the States, some centers would do optic nerve sheath fenestration almost routinely. Like that would be their first choice. Other centers would do shunts. At Sick Kids, when we kind of brought this up with everyone, the neurosurgeon said that the shunt would be super technically difficult because his ventricles are really small. And we pulled in Dr. DeAngelis to try to get his opinion. And he said he'd never done one in a child that young. I think he was 5 or 6 at the time. And that he thought technically it would be extremely challenging. So I don't, now that he's older, it might be a little bit easier. But at the time, it just seemed like both the VP shunt and the optic nerve sheath fenestration were too risky in terms of the technical aspect of it. And then that's why we ended up with this very kind of rare procedure of stenting the transverse venous sinus throat. But I'd be interested to know, my sense is that in some centers, they almost never do optic sheath fenestrations. In other centers, they do it all the time. I don't know, my sense is that here we don't do a ton of them, but I'm outside the adult world now, so I could be wrong about that.
So that's interesting because I did one during my residency training with my, because we had a very good neuro ophthalmology center in Birmingham, UK. And we had 4 neuro-ophthalmologists because we have a very large neurosurgery center. And so that was the thing. And one of the things that I sort of looked at was how soon you should do that. And obviously visual field is very important and visual functioning measurement. And that would be difficult in this child. So that's what I was asking the question. But I don't think it would be, it might be a bit more difficult, but a 4-year-old orbit is possible to get into to do optic nerve sheath fenestration, I think. Anyway, just a thought, because now when you look at it, you see he's got significant optic disc pallor, right? So I just wondered whether that was actually ever brought up to the parents and did they kind of consider it?
Yeah, no, all options were given to them. Everyone said that they would try whatever procedure they chose, and in the end they wanted the stenting. Although initially it looked like it worked, now he's back on a little bit of steroid, which is troublesome. So it might be something we have to readdress. We go grab Dan DeAngelis in a corner and see what he thinks.
Mike, there's another question here from Dr. Epstein. Oh, sorry, you were going to say something. I'm sorry.
I was just going to answer that. Yeah, I was just going to answer that same question.
Okay.
Nancy's just talking about trisomy 21 being both like a cause of high pressure and also having funny discs. Totally true. It seems actually IH is pretty rare in trisomy 21. We're having anomalous discs is super common. So every time you see a funny looking disc with Down syndrome too, I think it's much more likely to be anomalous than true papilledema or high pressure. Just it has been reported, but it's rare.
All right, thank you. And I think Dr. Reginald wants to make a comment as well about optic nerve sheath fenestration. Dr. Reginald, are you there?
Yeah, I am. Thanks. And I just want to echo exactly what Mike says about in terms of our reticence to do it. And then in terms of where I think most people agree it sits, it's sort of as a temporizing treatment that you would do if you feel that the vision is at risk, but it doesn't address the underlying mechanism of the problem of pressure. So yes, you might do it in a situation where you're thinking that this nerve in particular is at risk, but ultimately you need to have a long-term plan about how you're going to reduce the pressure.
Awesome. Well, I think we're getting kind of close to 8:30. Thank you so much, everyone, for contributing and staying around and listening. And an awesome job by Marco and Seema. You guys are great. Appreciate that. I guess if there's any last questions, otherwise should we wrap it up?
Yeah, I think that's it for the questions. So thank you, Mike, Seema, and Marco. Excellent presentations. Thank you for your efforts. As a reminder to everyone, next week is the last Grand Rounds of 2020. This year is almost over. The next week's lecture will be from Dr. John Lloyd, our program director, who's just led us through an incredible Royal College accreditation process, and he will be talking about resident education. So it'll be an interesting topic next week. And then after that, we'll resume in 2021. So we'll see you guys next week. Thank you to the speakers once again. Have a good day, everyone.
Thanks, somebody. Appreciate it.